All right, I think we'll go ahead and get started. Thank you so much for being here and joining this workshop. My name is Allison Kimball, and I'm an endocrinologist at the Mass General Diabetes Center. And I'm delighted to also be joined by one of my colleagues, Tiffany Soper, a nurse practitioner in our clinic. And this workshop is on challenging diabetes cases with a particular primary care focus. And as we go through, feel free to type questions or comments into the chat, and we'll have opportunities for hopefully some discussion throughout. All right, so let's go ahead and get started. So we'll jump right in with a case. So this is a patient of mine, RB, 57-year-old male who has type 2 diabetes and obesity, and he's presenting for follow-up. His diabetes medications are metformin, 1,000 milligrams twice a day, empagliflozin, 25 milligrams daily, which was increased from 10 milligrams about 3 months ago when his A1C was 7.7%. He's also on glargine 50 units daily. And today he reports that he's lost 12 pounds since starting empagliflozin. His BMI currently is 40 kilograms per meter squared. His fasting finger stick blood sugars are between 80 to 110 milligrams per liter. Pre-meal finger stick blood sugars are 110 to 130 on average. He's not having any hypoglycemia, and his hemoglobin A1C today is 7%. So on the next slide, we'll jump in with a poll question. The question is going to be, just so you can have a chance to review this data, the question is going to be, what do you do with his medications? So he's A1C 7%. You can see what he's on. And so we'll jump right into the first poll question, Tiffany. All right, so let's see here. So this is an interesting array of answers. This is great. So the majority, 50%, said they would add a GLP-1 receptor agonist and reduce the glargine dose. The next most popular answer was to make no changes, followed by reduce the glargine dose, and then just a few responses for adding a GLP-1 receptor agonist. So I actually think that there's probably multiple right answers. And as we know, with diabetes, there's not one right answer, probably multiple ways of approaching a case. In this particular case, what I did first was chose to reduce the glargine dose. I definitely, and this was actually a few years ago. And so now if I was seeing this patient, I might approach it differently, but I definitely think D is a reasonable option, adding a GLP-1 receptor agonist, but also reducing the glargine dose. If you're going to add a GLP-1 receptor agonist for this patient, I probably would empirically reduce the insulin dose, and we'll come back to that a little bit later. But what I would highly suggest not choosing in this particular case is to make no changes, which I think you could be tempted to say, let's make no changes. He's lost some weight, his A1C is well controlled, and that is all true. But I would just encourage you to think about his weight and the effect that his medications are having on his weight. So in this case, what we did, as we reduced his glargine dose, he continued to lose weight. And within 6 months, he was actually able to stop glargine entirely, and his A1C remained well controlled. So it's important to note that during this insulin wean, the blood sugars might increase slightly. And so you must be willing to tolerate some degree of hyperglycemia in the short term. And so because of this, it is important for patients to continue to monitor fasting blood sugars and increase insulin, if the fasting blood sugar, rises significantly above 140 or 150 or whatever your target is. And so that's what we did in this particular case. And he did really well. And so the sort of key takeaway for this is to always consider the effects of insulin on weight. And so in all patients, but especially patients with overweight or obesity, using the minimum insulin dose necessary to achieve the target A1C is really important. And if possible, try to stop insulin. So how can you do that? Well, first of all, as we know, it's just really hard to lose weight on insulin. So maximizing the use of insulin sparing medications, as was mentioned, like adding a GLP-1 receptor agonist or metformin or an SGLT2 inhibitor, emphasizing the importance of diet and exercise as reducing insulin. So this works, really well if patients are also highly motivated to lose weight. I would say it works even better. So if they are also, increasing exercise, watching their diet, it can work particularly well, I would say. How does this work? So it's really this nice cycle of positive feedback, and this is how I explain it to patients. So as we reduce their insulin, it will allow them to lose, in some cases, a little bit of weight. And again, that works better if patients are also kind of putting in some effort. And as they lose weight, they lose less insulin. And so then we're able to reduce their insulin further, and then they lose more weight. And again, less insulin is required. And it really can work out quite nicely. And it feels really good to be able to reduce insulin and stop insulin in some cases. So as I said, you do have to be willing to tolerate some degree of hyperglycemia in the short term. So it may not be reasonable to start reducing the insulin dose until the A1C is close to goal. So in this particular case, the A1C was 7%. Our goal was less than 7 for this patient. So, if his A1C was, I would say, less than 7.5, I might consider starting to reduce the insulin. But if it's over that, then probably not the appropriate time to consider doing this just yet. So here's a twist on this same case. This will be a really easy poll question. So same patient, he's on the same medications, except his A1C is not 7%, it's 7.8%. His BMI is 40 kilograms per meter squared. And so the question is, what medication would you add? And so we'll just jump right into the next poll question. All right, so good. The majority chose adding a GLP-1 receptor agonist or a GLP-1 receptor agonist. A few chose adding prandial insulin, which is is not unreasonable, except that I think there's probably a better option, which is, a medication like a GLP-1 receptor agonist to address the glycemic control, but also weight loss potentially. So that is what I would have done. And we'll spend the next sort of section of the talk reviewing some of the options for GLP-1 receptor agonists and also some of the primary data. And this might be a slight review from some of the what you went through in the larger talk. So this is a reminder of the options that are available. The order that I list them here is my personal order of preference, because commonly I'm thinking of the weight loss benefits and additionally the cardiovascular and renal benefits. And so the weight loss benefit is greatest for tirzepatide, which is a dual GLP-1 receptor agonist. The starting dose is 2.5 milligrams and can be increased to as high as 15 milligrams. The cardiovascular outcome trial for tirzepatide is still ongoing, but it has been shown to improve dyslipidemia and blood pressure, and there are renal benefits. Semaglutide is available as a weekly injection in doses ranging from 0.25 milligrams to 2 milligrams for Ozempic, and then doses up to 2.4 milligrams for Wegovy, which is approved for patients with obesity as a weight loss medication. For dulaglutide, the starting dose is 0.75 milligrams, and you can go as high as 4.5 milligrams, with higher doses leading to greater weight loss. Liraglutide has similar benefits to dulaglutide, but and the weight loss benefits of the highest dose, which is 3 milligrams, can be significant, but it's a daily injection, and many patients prefer a weekly injection. And then finally, exenatide and lixisenatide are generally associated with less weight loss and don't have the same cardiovascular and renal benefits as the others. So those are generally my less preferred options. I think those of us who prescribe these medications know that even though you may have a personal preference, that the insurance company often will dictate what your options are. And then also the availability of these drugs has been very limited at times, which has made things challenging. But let's dive in more detail to tirzepatide, semaglutide, dulaglutide, and oral semaglutide. So I'll just briefly go through some of the primary data to sort of show you the efficacy in comparing these medications and their doses. So tirzepatide, as I mentioned, is the newest available agent. It's a dual GLP-1 and GIP receptor agonist. These are data from the SURPASS-2 trial, which was a study of 1,800 patients with type 2 diabetes who had a baseline A1C of 8.28% and a BMI of at least 25 milligrams per kilogram at least 25, excuse me. And they were assigned to receive tirzepatide at a dose of 5 milligrams, 10 milligrams, or 15 milligrams, or semaglutide 1 milligram. And they were treated for 40 weeks. The graph on the left shows the overall change in A1C from baseline, and the graph on the right shows change in A1C over the course of the 40-week study. And the arrows that are there on the x-axis indicate when the maintenance dose was reached. So you can see that tirzepatide at all doses was superior to semaglutide in reducing A1C, and the greatest reductions in A1C were seen as the doses of tirzepatide were increased. So it's very effective for improving diabetes control. But now let's think about the change in weight, which is also very impressive, as you know. So the graph on the left shows change in body weight from baseline, and the graph on the right shows change in body weight over the course of the 40-week study. As you can see, reductions in body weight like A1C were also greater with tirzepatide than with semaglutide at all tirzepatide doses. And greater weight loss was seen as the dose of tirzepatide was increased, and weight loss for all groups did not plateau by 40 weeks. For patients who were on the highest tirzepatide dose, 15 milligrams, the overall mean weight loss over 40 weeks was 12.4 kilograms compared to 6.2 kilograms for semaglutide. And that's equivalent to a 13% reduction in body weight, which is a very impressive amount of weight loss. In terms of side effect profiles, the GI-related side effect profiles for tirzepatide was similar to that reported for GLP-1 receptor agonists, with nausea being the most common side effect, followed by diarrhea. So I would say the take-home point for this study is that tirzepatide is highly effective for glucose lowering and weight loss in patients with type 2 diabetes and obesity, with a superior A1C reduction and weight loss when compared to semaglutide 1 milligram weekly. And again, we don't have the kind of final data on the cardiovascular outcome trial, but that should be coming. So we'll move now to semaglutide, comparing the 2 milligram and 1 milligram doses. So in this trial, it was a trial of 961 patients with type 2 diabetes who were inadequately controlled on metformin, plus minus a sulfonylurea. Their baseline A1C was 8.9%, and they were randomly assigned to once weekly semaglutide 1 milligram or 2 milligrams for 40 weeks. In the graph on the left, you can see change from baseline A1C is on the y-axis, and time since randomization is on the x-axis. Reduction in hemoglobin A1C was greater with semaglutide 2 milligrams compared to 1 milligram. As you can see, the decrease in A1C was 2.2 percentage points with semaglutide 2 milligrams and 1.9 percentage points with semaglutide 1 milligram. And these differences, so they're statistically significant, although I'd argue that clinically the difference between them is relatively modest. And then now looking at weight, the change from baseline weight here on the right-hand graph is presented on the y-axis, and time since randomization is on the x-axis. And you can see that the weight loss was also greater with semaglutide 2 milligrams compared to 1 milligrams. And so patients who were on the 2 milligram dose lost on average 6.9 kilograms over the 40-week trial, compared to 6 kilograms for patients who were on the 1 milligram dose. And the side effect profile in terms of the GI side effects and also serious adverse effects were similar between the two groups. So in summary, the investigators conclude that semaglutide 2 milligram is superior to 1 milligram in reducing A1C with additional weight loss and a similar safety profile. So the higher dose therefore provides a treatment intensification option for patients who have type 2 diabetes treated with semaglutide who are in need of additional glycemic control. All right, we'll move now to dulaglutide. So this is the Award 11 trial data. This was a trial of 1,800 patients with type 2 diabetes who were inadequately controlled on metformin, who had a baseline A1C of 8.6%. They were randomly assigned to once weekly dulaglutide 1.5 milligrams, 3 milligrams, or 4.5 milligrams for 52 weeks. The primary objective was determining superiority of dulaglutide 3 milligrams and or 4.5 milligrams over the 1.5 milligram dose in terms of A1C reduction at 36 weeks. And secondary superiority objectives included the change in body weight. So again, here on the y-axis is the A1C change from baseline. X-axis is weeks. At 36 weeks, dulaglutide 4.5 milligram provided superior A1C reduction compared to 1.5 milligrams. And these differences were maintained at 52 weeks. Dulaglutide 3 milligrams was superior to 1.5 milligrams for reducing A1C using the efficacy estimate, but not the treatment regimen estimate, which is a more conservative estimate of effectiveness in populations in whom patients may not adhere to treatment. So regardless, clinically relevant improvements in A1C were seen in the 3 milligram dose group. So now moving to the weight data, patients whose dulaglutide dose was escalated from 1.5 to 3 milligram and to 4.5 milligram had greater reduction in body weight compared to those who were maintained on the 1.5 milligram dose, and that started at 12 weeks. The mean weight loss at 36 weeks was 4 kilograms for patients on the 3 milligram dose and 4.7 kilograms for patients on the 4.5 milligram dose. And there was additional weight loss that was observed also in each dose group at week 52. In comparing the data for semaglutide that I just presented and the 4.5 milligram dulaglutide dose, the maximum dose, both the A1C reduction and the weight loss were marginally greater for semaglutide. And then just briefly, here's a summary of adverse events for dulaglutide as part of this trial. Most commonly reported side effects as expected were nausea, diarrhea, and vomiting, although there were very few severe cases. The incidence of each, although numerically higher in the higher dose groups, was similar between the 3 and 4.5 milligram doses, but higher than what was seen in the 1.5 milligram dose group. So in conclusion, this trial demonstrated glycemic and weight benefits for patients using the higher doses, the 3 and the 4.5 milligram doses of dulaglutide, without meaningful changes to the safety profile. And so, you know, they say that the availability of 4 clinically efficacious doses provides additional tools to help patients achieve and maintain glycemic control and also achieve weight loss goals. Especially if patients are already on the 1.5 milligram dose, intensifying that will lead to benefits without, you know, major significant increases in adverse effects. All right, and then the last one I'll review is oral semaglutide, and then we'll pause and see if there are any questions or comments. So I just thought this would be helpful to mention because this is an oral option for patients who may not be amenable to taking an injection. So this particular study sought to assess the relative efficacy and safety of once daily oral semaglutide 14 milligrams versus the injectable GLP-1 receptor agonists. And this was done in patients with type 2 diabetes who were inadequately controlled on basal insulin. And this is a network meta-analysis. So you can see here the list of the injectable GLP-1 receptor agonists that were included in this meta-analysis. And as you can see, once daily oral semaglutide 14 milligrams was associated with significantly greater A1C reductions versus most of the comparators, except not for the semaglutide 1 milligram dose. And now thinking about weight, they found that oral semaglutide was associated with significantly greater weight reductions versus exenatide 2 milligrams, lixisenatide 20 micrograms, and there were non-statistically significant weight reductions in favor of oral semaglutide versus the other comparators, with the exception, again, of the semaglutide 1 milligram dose. So their conclusion was that once daily oral semaglutide 14 milligrams as an add-on to basal insulin is an efficacious treatment that offers people with type 2 diabetes the option of an oral treatment with similar or perhaps better efficacy and similar tolerability compared to other injectable GLP-1 receptor agonists. All right, so before we come back to this case, let me pause and I'll ask Tiffany to let me know if there are any questions in the chat or comments.
We have a few questions coming in. Practical issues, looking for suggestions while stocking with the supply chain shortage. What happens if a patient takes a week off if they are unable to get their prescription, and potentially bridging with glipizide?
This is a really challenging but very frequent occurrence, and I'm sure, Tiffany, you may have some thoughts on this, but I'll just briefly share. Yes, I think we get messages every single day from patients who are inquiring about what to do because their GLP-1 receptor agonist is not available. So things that I've done, in addition to encouraging them to call around to pharmacies, including big name pharmacies like, you know, here in the US, like Walmart and Costco, would be to find out what other doses might be available, if any, of the GLP-1 receptor agonist that they're currently on. And so if there's a lower dose that's available, perhaps temporarily lowering their dose. Certainly considering switching to an alternative if it's covered by the insurance and if that's also available. But we've had so many issues with supply problems affecting all of these medicines that that's not probably the best practical solution. For patients who are on insulin, I usually advise them that they'll have to, if they're off their GLP-1, they'll have to be increasing their insulin. And so that's what we typically do. Could you add an alternative medicine like glipizide in the short term? I think that's certainly reasonable, you know, if really absolutely necessary to help with maintaining blood sugar control, but probably not something I've commonly done. Tiffany, do you have any thoughts on this, or what have you suggested to patients when this?
Well, one other little tidbit is that if a patient, CVS and Walmart, which are the two biggest chains, they use the same supplier. So if you normally get your supply at CVS, don't try Walmart, try like a grocery store pharmacy like Costco, or maybe a smaller apothecary that have different suppliers potentially, but it's very challenging for us and our patients, and it's a lot of legwork to be calling around.
So thank you for raising the question. It's definitely practically a major challenge that we have. All right, so let's come back to this case again, where we sort of decided the next best option would be to add a GLP-1 receptor agonist. And actually, so the question is going to be that we decide to start tirzepatide 2.5 milligrams daily. These are his medications he's currently on. His A1C is 7.8%. And the question is, would you advise an empiric change in the glargine dose? So we can go ahead and I think launch the poll, Tiffany. All right, great. Wow, I'm impressed with this one. So the majority said yes, they would reduce the dose by 20%. And then a few people said, no, continue the same dose or reduce by 50%. And so I would agree that that I would reduce the dose by 20%. And in general, it's advised that if someone is on basal insulin and you're adding a GLP-1 receptor agonist, if their A1C is less than or equal to 8%, to go ahead and empirically reduce their dose, as opposed to just kind of waiting to see what happens or waiting for them to develop hypoglycemia. So we've talked about this, and there are a lot of benefits to combining a GLP-1 receptor agonist with basal insulin. It can reduce hemoglobin A1C and reduce body weight. It will help to optimize the prandial endogenous insulin response to control postprandial glucose. And compared with the addition of mealtime insulin to basal insulin, a GLP-1 receptor agonist produces similar or greater reduction in A1C, leads to weight loss instead of weight gain, and less hypoglycemia. So I would absolutely encourage you to consider this option unless there is a contraindication to a GLP-1 receptor agonist. And so as I mentioned, in patients who are starting this, the dose of basal insulin should generally be decreased by 20% if the A1C is less than or equal to 8%. And then you can wait, 4 to 5 weeks on a stable dose before continuing to titrate the insulin, unless, of course, the patient develops hypoglycemia, in which case, they should go ahead and reduce their dose as soon as they have hypoglycemia. Now, thinking about this in the reverse, starting basal insulin on top of a GLP-1 receptor agonist, this is not that much different from starting basal insulin in general. You want to start this with a slow titration to target a goal fasting blood sugar, whatever your goal is. You could consider starting the insulin dose at 10 units per day or 0.1 to 0.2 units per kilogram per day, and then increase the dose by 2 units every 2 to 3 days for a target fasting blood sugar. If you're aiming for an A1C of less than 7%, then aiming for a target fasting blood sugar less than 80 to 130 milligrams per deciliter. So I'm going to jump into the third case. So this is also a patient of mine, a 69-year-old female who has type 2 diabetes complicated by stage 3 chronic kidney disease. She also has obesity, diastolic heart failure, non-alcoholic fatty liver disease, hypertension, and hyperlipidemia. And she was referred by her primary care doctor due to uncontrolled diabetes. Her medications at the time that I saw her, she was taking Degludec U200, 170 units twice a day, Aspart 20 to 40 units with meals, and liraglutide 1.8 milligrams daily. On exam, her BMI is 46.5. She had no features to suggest Cushing's or acromegaly. She did have central adiposity, and some skin tags, as well as thin, pale striae. At this time, she was checking fingerstick blood sugars 3 to 4 times per day, and she reported values in the 300 to 400 range. The lowest value she had seen recently was 131, and that was a day that she did not really eat. Her A1C was elevated to 13%, and her creatinine is 1.33 with an estimated GFR of 67. So I just want to pause here and just invite you to share in the chat, what questions might you ask her as you're considering her management plan, and also thinking about medications that she's currently prescribed. And share with you what I asked. Okay, let's see here. Okay, great. So your diet and exercise habits, certainly. Her diet was actually relatively healthy, relatively low carbohydrate. She did not, consume sugary beverages. She was not particularly active because she did have some joint pain related to arthritis. There was a comment, does she have any signs of lipodystrophy or at injection sites? And I can't recall offhand if she did, but that's a great point. Med compliance. So yeah, certainly one of my major questions is like, these are high doses of insulin. Are you, have you missed doses? How frequently do you miss doses? She actually was fairly, at least reported, fairly consistent adherence to insulin. So she really rarely missed doses of insulin. Any other thoughts? Affordability is a good one too. So yeah, I think, you know, just considering certain medications are on patients' lists, are they actually taking them? Have they become too unaffordable and they're just still stuck on the medication list? CGM, yeah. So at the time I saw her initially, she was not on a CGM, but it was something that we talked about and we got her on one. And I think that also has been very, very helpful with her with making some changes to her diet. So as I mentioned, it was relatively healthy, but there were improvements to be had. And I think when she saw the real-time data, that was kind of helpful for her. Other things, so I you know, I asked her about other medications she had tried. So it's she was, because she was not on metformin and her kidney function, she had some CKD, but her kidney function at the time I saw her was, you know, was not terrible. So she said she had been on metformin in the past and it was discontinued. She wasn't sure why. She doesn't recall if there were any side effects. The Victoza that I mentioned that she's taking was started about a year ago, and she does not recall, well, at the present time, she doesn't feel like, you know, she can't tell if it's having an effect. She does not have any early satiety. She does not recall whether she had any weight loss with it, but she doesn't think she had any significant weight loss with it. So pharmacologic options. So just go ahead and share in the chat, what are medications you might consider putting on her plate or changes you might make to her current medications? There might be more than one. There definitely are more than one option. What would you do in this case? And then I'll share what I considered. So consider a switch to Mounjaro or Ozempic. I like that. Consider addition of metformin, switch liraglutide to tirzepatide. Yep, consider an SGLT2 inhibitor, change to a better GLP-1 receptor agonist. So that's a theme here. Adding metformin, Mounjaro, consider Jardiance once the A1C is lower. I agree. That's a good point about you know, adding an SGLT2 inhibitor. We tend to wait on that until the A1C is a little bit lower, just to avoid, you know, significant polyuria and the risk of yeast infections that can come with that. Great. Multiple people commenting here on things they would do. All right. And one comment about switching to U500 insulin. Given the high doses of insulin, consider bariatric surgery. Wonderful. These are all great things to consider. Things that I considered are very similar: starting metformin, increasing liraglutide versus switching to something else like semaglutide or tirzepatide. This was actually a few years ago, so before tirzepatide was available. Considering starting an SGLT2 inhibitor, perhaps once the A1C is a little bit better controlled, switching to U500. So these are the bolded items are all of the things that we did at the start, although probably if I was seeing her now, not a few years ago, I would have just gone ahead and switched her to tirzepatide. And so I want to just switch gears and talk a little bit about concentrated insulins. So you know, in terms of absorption of insulin, the rate of absorption of insulin is inversely proportional to the dose. So at high doses, the volume that's injected can be very large and lead to much slower absorption. And the slower absorption can also lead to a blunted peak of insulin. And there also can be decreased absorption if the volume of insulin is very large. So concentrated insulins are more potent for a given volume. And just to remind you, some nomenclature and the general principles: U100 insulin, which is our standard insulin, is 100 units of insulin in 1 milliliter volume, versus U500 is 500 units of insulin in 1 milliliter. So the same dose of insulin can be delivered, but in a much smaller volume, and leading therefore to improved absorption. So when converting a patient who is well controlled with a risk of hypoglycemia, what we typically would do is calculate the total daily dose of insulin and then give less, like perhaps 20% on a unit for unit basis. if someone has uncontrolled diabetes, you may not necessarily need to reduce their dose when you make this conversion. So Humulin R U500 is the original concentrated insulin, which peaks at about 4 to 6 hours, lasts for 10 to 16 hours, can be given twice a day or 3 times a day. Expensive, but costs less per unit than high dose U100. And as I mentioned, can be more effective due to improved absorption. Hopefully there aren't patients around there who are using U500 syringes, because I just, compare here the U100 syringe on the left versus the U500 syringe on the right. They're the exact same size, so 1 milliliter, but the U500 syringe is labeled is 100 to 500 units, and the U100 is labeled as 10 to 100 units. And so the syringes, as you of course know, are very error prone and can be really dangerous. Imagine if you inadvertently use the U100 syringe to draw up U500 insulin. You can pre-fill syringes, and those are stable for up to 28 days, but certainly a much, much better, safer option would be the U500 insulin pen, which is here, much less error prone. It's a 5 milliliter pre-filled pen that contains a total of 15, and the pen dials in 5-unit increments up to a maximum dose of 300 units per injection. So I believe it is more expensive. So unless cost is a major factor, I would strongly consider the U500 pen over the syringe, given the safety concerns. So here are the pharmacokinetics of U500 compared to U100 at doses of 50 units on the left and 100 units on the right. The U500 is the solid black line, and the U100 is the dashed line. At high doses, U500 compared to U100 has a blunted peak and a longer duration of action. And here's data from a meta-analysis of studies assessing the efficacy of switching to U500 insulin as either multiple daily injections or a continuous subcutaneous insulin infusion, which would be an insulin pump. In the 9 studies assessing the multiple daily injections, A1C improved by 1.59%, weight increased by 4.4 kilograms, and the total daily dose increased by 59 units. In the 6 studies assessing insulin pumps using U500, there was a similar A1C improvement compared to the multiple daily injections. No significant weight gain or change in total daily dose, but the kinetics were very challenging, as you'd imagine. I don't have any patients on a U500 insulin pump. Tiffany, I don't know if you do or have any experience with that, but it can be challenging.
From years ago, we used to do that a little bit more, but now I think we're trying to use some insulin sensitizers more.
I think that's a great idea. There are other concentrated insulins, just to remind you, in addition to U500, and I won't go through these in detail, but these are just here for your reference. So Glargine U300, Degludec U200, Lispro U200, and there are others as well. So just coming back to this particular case, to switch to U500, the first step is to calculate the total daily dose. So this patient was taking 170 units twice a day of Tresiba U200. She was taking 20 to 40 units with each meal of Novolux. So approximately 430 units per day was her total daily dose. As I mentioned, you may want to consider a reduction in the dose if the A1C is less than 8 or the patient's at high risk for hypoglycemia, or if you're adding another medication at the same time, like a GLP-1 receptor agonist, and then decide on whether to have the patient take this twice a day or 3 times a day. If you're doing it twice a day, then it's typically advised to give 60% as the first dose, 40% as the second dose. And if you're doing it 3 times a day, 40% of the total daily dose is the first injection, and then 30% of the total daily dose is the second and third injection. In terms of whether to consider BID versus TID, the frequency might depend on patient preference, with further titration and intensification as per, the glucose effect. In general, 3 times a day, U500 might be needed in individuals who are quite prone to post-lunch or pre-dinner hyperglycemia. So perhaps patients who are post-transplant, or who are on glucocorticoids, for example. So in this particular case, what we did is I mentioned the total daily dose based off of what she was previously taking was 430 units. We decided to reduce that to 400 because we were starting metformin at the same time and also increasing the liraglutide dose. And we went with TID dosing, so 160 units at breakfast, 120 units at lunch and dinner. We also got her plugged in with a CGM. And then over the course of the next few months, had multiple conversations about insulin titration. And then her A1C 3 months later was quite impressive at 8.4%. So she really did quite well. So I'll pause here again before we jump into about CGMs in more detail to see if there are other questions or other comments.
Allie, there were quite a few questions about SGLT2 inhibitors and your concern with initiating it at a 13% and also about renal function and when it is advisable to not start a SGLT2.
Absolutely, yeah. And again, Tiffany, would be interested to hear your thoughts as well. But in general, I mean, I think SGLT2 inhibitors have great benefits. I'm not going to go into detail in this workshop on those, although maybe next year I should add something about that. But they have great benefits. They have weight loss benefits, kidney benefits, as you know. And so if patients have elevated urine microalbumin or they have CKD, meaning they have a strong indication to be on an SGLT2 inhibitor, like this particular patient did have CKD, then I would definitely consider adding it. The main sort of risks with them in general would be, euglycemic DKA, which we've definitely seen quite a bit of. And then, yeast infections, other genital urinary infections, including severe GU infections, which is, pretty rare. So usually I tend to avoid starting them until if the A1C, and I'm not sure if there's guidelines about this, or Tiffany, what you do, but if the A1C is high, like for me over 10%, I tend to wait on adding them until their A1C can come down a little bit, only because I've seen in some cases pretty significant kind of volume depletion that comes with the polyuria. If starting the SGLT2 inhibitor and the A1C is very high, and also just a really high risk of yeast infections in women. And if they have one yeast infection, I don't necessarily sort of say, okay, that's it, we have to stop this indefinitely. But I just find that many patients are not really willing to consider going back on it. And they're just such great medicines with good kind of outcome data that I like people to be on them if they can be on them. So I usually will wait. What's your?
Yeah, I think that very similar to you. I was thinking around 9 or 10%. I'm concerned about the long-term success of being on these medications. I also feel a little more comfortable starting somebody who is on basal insulin, an SGLT2 inhibitor, just my concern for increased risk of euglycemic diabetic ketoacidosis, which is rare, but we have seen cases of that. And so I just feel like it's reducing the risk of the diabetic ketoacidosis, so I feel safer starting patients with a little bit higher A1Cs on the SGLT2 inhibitors.
And then what about kidney function? What's your typical, so, for me generally, the most commonly prescribed SGLT2 inhibitor that I use is empagliflozin, and patients can be on that even if they have, CKD. Of course, there's benefits to those patients being on them, unless their, estimated GFR is quite low, like less than 20, less than 25, I may not initiate it. But otherwise, I feel generally comfortable with them being on it.
Yeah, I'm not concerned about it giving them more side effects. My concern with the lower GFR is that it's just not going to be efficacious.
That's such a good point. Yeah, absolutely.
Mm-hmm.
Glycemic benefits. So yeah, that is very true.
And there is one more question if you'd like to weigh on. Somebody's asking, what do you think is a more important surrogate marker for most type 2 diabetes, A1C or weight, especially with us using so much of the GLP-1s now?
Yes. I mean, I would still, this is, it's a diabetes workshop and we're diabetologists. I would I would still, really look number one at the A1C and trying to get that a goal just in terms of, reducing what we know and studies that have been, that have been done looking at risk of microvascular disease and macrovascular disease. But weight is so critically important. So they are really both important, I would say. And I always, my kind of point of doing that first case is just to highlight the fact that I think we all in diabetes are looking at the A1C as we should, but it's easy to kind of forget about the weight and the impact medicines that we are prescribing have on weight. So I think they're both very important, and looking at them both every time you're seeing a patient, I think is really important.
Yeah, and I think it's more challenging when you're right at the cusp, which one you prioritize, but certainly, with the elevated A1Cs, that's going to take priority, and we're going to put them on the insulin, even if that does give them a little bit of weight gain.
Yeah. Okay, great. Any other questions before we jump into Tiffany?
I think we covered most of them.
Okay, great. So let me advance to, we have a couple of slides on continuous glucose monitors, and I was hoping Tiffany could just sort of help us think about these and which patients you may consider these for, and kind of comparing, contrasting what's available. Tiffany, a lot of patients in our clinic, and especially a lot of patients with type 1 diabetes, and has a lot of experience with technology in general. So I was hoping you could lead us through this piece.
Thank you. I'll just start with the continuous glucose monitors. You're probably very familiar with them. There's a lot of advertisements to them as well. They're little devices that are testing the glucose, the interstitial glucose, not the blood glucose, every 1 to 5 minutes. We're using predominantly the newer versions, but we have a lot of our patients on the Dexcom 6 and the Freestyle Libre 2, kind of just finishing up their supplies and using those up. The continuous glucose monitors are super helpful for my patients and being able to monitor their blood sugars every 5 minutes and just following the trends, looking to identify which we're trying to really engage them in the very challenging self-management of type 1, evaluating the impact of their exercise on their glycemia and the impact in learning how different foods affect them. You can find anything on the computer about a food, whether it's good for your blood sugars or if it makes it go too high. And so this is really empowering to my patients to get them to understand how different foods impact their diabetes. Let's see what's on it. So I think that in general, as is with much things today, the similarities between the different devices are far more overlapping than the differences. All of them have about a 10% MARD, right around that area. That is where they are spending 90% of the values are in the range where they would not make a clinically significant difference in medication management. So we have the Dexcom 6 and the 7 are probably the technology we are most using, in large part because they are mostly connected with the insulin pumps. Freestyle Libre has come out and been really great at driving down the cost because they're really driving the technology and the cost for continuous glucose monitors. We're using those a lot for our patients. Medtronic has their Guardian 3. It predominantly is only being used for our patients that are on the Medtronic pumps. We have some of the patients using the Eversense continuous glucose monitors. Those are unique in that you go into the office every 3 to 6 months to get it implanted, a little transmitter implanted under the skin. And Stella's not available just yet, but it's been FDA approved. These are by and large used by the patients. They change them for the Dexcom every 10 days. And then the Freestyle Libre, they're changing them every 14 days. Very simple technology for our patients to use. For the vast majority of my tech savvy, patients, they are just using it on their phone and they'll watch a video and they're able to get themselves started. For our patients that are a little bit more concerned, we generally bring them into the practice and teach them how to use the continuous glucose monitors. So I think our patients who are type 1 diabetics, we think of continuous glucose monitoring as just standard of care today. It is, they have so much glucose variability. It's going to alert them if it's their blood sugars are going too low. It's been, from my practice with my type 1 diabetics, I've had so many fewer car accidents and severe hypoglycemic events because these devices are beeping for them and alerting them to an upcoming hypoglycemic event. And I think that any of my patients who are taking a basal bolus regimen, you know, I offer that to all of my patients. If you really should be looking at your blood sugar before taking insulin, if you're doing that more than once a day, you know, I think that it's pretty standard for us to have our patients using the continuous glucose monitors. I think basal insulin can be a little bit more in the middle of where we think about if somebody's just on basal insulin only, they may not have as good of insurance coverage if they're just taking one insulin injection a day. For a lot of commercial insurances, you need the diagnosis of diabetes and insulin once a day. There are some insurance companies that'll cover it for anybody with a diagnosis of diabetes. So I do have a small number of tech savvy patients that just really want to be managing their blood sugars. And we think it can be reasonable for somebody to be managing their blood sugars when they're only on maybe a GLP-1 or potentially on sulfonylurea or other oral medications. But once a day, most of our patients will get their continuous glucose monitor covered. It's so highly variable how much this is going to cost our patients. But in general, it's fairly similar to glucose monitoring. Medicare, as long as there's a diagnosis of diabetes, so it doesn't have to be a type 1 anymore, and they're using insulin at least once a day with some other indication, we can get that covered for them. The big caveat with the Medicare is that it's not covered through pharmacy benefit. Medicare covers at 100%, so it's fully covered. You have the Medicare covering the 80% and the secondary covering the remaining 20%. So my patients with Medicare, if we're appropriately sending it to a durable medical supplier such as Edge Park, we are able to get it covered 100%, which is really great because that'll be actually cost savings for a lot of my patients who are going to the pharmacy for their finger sticks. The requirements for Medicare is you have to have it documented in their notes, the diagnosis of diabetes, and that they're using insulin, and that has to be submitted to the durable medical every 6 months. So this is great coverage. It's challenging that it has to go through DME, and we are just fortunate to have designated staff that are helping us with all this onerous paperwork. Let's see. Other thoughts, Allie?
Any sort of practical differences between Dexcom and Libre? If a patient's like asking you, is there one that's better than the other? What to consider? What do you usually tell them?
The only concern that I have in my practice, I have a lot of type 1s as well, is if it's going to integrate with their insulin pump. Other than it integrating with the insulin pump, I think the Dexcom 7 and the Libre 3, their size is very similar. The Libre 2, you have to hold up your phone or the receiver to scan it, but now the Libre 3, it automatically is communicating and alerting for you if you're having lows. So both of the technology, there's been improvements and they've come more close together, and there's very little differences between the Freestyle Libre 3 and the Dexcom 7 at this point.
And then what about, I just thought it might be helpful if you have any tips for patients who are using CGMs. And
yeah,
a lot of calls and messages from patients with issues with their CGM.
Yeah. I think that this is where all the meat is. You, of course, it's like getting our patients. I have so many that just scan and they're not thinking about it. So I'm really trying to get my patients engaged more with their diabetes when I'm having them wear the CGM. So I'm trying to get them to pay attention to their food and how they can modify their diet. Then it is sites. Especially this patient here, you can see he's wearing his Dexcom on the back of his arm. If you are going to be laying on your side and compressing the continuous glucose monitor, you are going to get a false low. So I have a lot of patients that they'll lay on the side of their arm, especially if they're wearing it a little bit more on the external deltoid area. You're going to, if they lay on the side, they can get a false low overnight. So I like to warn my patients, review sites, and ask them if they, so just going back a second, I think the most important thing is that they understand that this is not going to give you exact values. We're going to get, even like with your finger stick values, your blood sugars are going to be 10% off. And so if the blood sugars are very high, you're going to have a larger spread between the finger stick and the CGM values. I like to make sure that they're aware that not only does it have the glucose value, but the arrow that it's predicted to be. So where it's trending. So a blood sugar at 110 and rising is different than a blood sugar at 110 and dropping. So when the other thing that I mentioned earlier is that it's measuring the interstitial glucose value, like at the back of the arm, not into indwelling catheter into the bloodstream. So there is up to a 15-minute delay between the finger stick value, which is measuring the blood glucose, and the CGM value. So if you have a patient who, they're looking at their blood sugar and it's 160 on the Dexcom, but rising, and then you see the finger stick is 190, they might think this is a large discrepancy, but when you think about where it's going to be in 15 minutes, that's probably more accurate than if you get the same number, depending on the trend arrow. So just having a healthy level of cynicism. If you're, these are disposable devices, you change it every 10 or 14 days. It's great technology when it's working, but you're going to have some sensors that don't work as well as others. You can do finger stick values to calibrate. If you have a question, it's going off saying that your blood sugar is 40, but you feel normal, do the finger stick to confirm hypoglycemic events and just to have a general sense for, do these numbers make sense?
That's really helpful. And a lot of questions about, and I'm hoping you can address this, what about skin irritation, skin problems with the adhesive? What would you suggest?
So I'm always amazed how terrible some of these skin reactions can be. And I recommend for a first step using Flonase or another glucocorticoid nasal spray. If you spray that on the skin before you apply the sensors, that really helps resolve the vast majority of contact dermatitis I'm seeing with my patients. We use the aerosol from the nasal spray because that you put it on, then it'll dry, compared to putting on like an over-the-counter. You wouldn't want to put an over-the-counter cream or gel. That'll just make it greasy, and it's not as likely, it won't stay on the full 10 days if you're putting that on first. So the Flonase works really well for most of my patients with mild contact dermatitis. If it gets more severe, there are other, once in a while we'll put something like Tegaderm down underneath it if we just cut a little bit of hole in the middle. I would say that there are a lot of resources online. For example, Panther Diabetes. They're based out of, it's a great group that's providing a lot of information on pumps and continuous glucose monitors for healthcare providers and for patients. And they have a whole sheet on troubleshooting skin issues.
And someone's shouting out Panther in the chat. That's really awesome. Thank you.
Yeah, they're amazing. They're doing great work out there.
And we have a little time, so just a few more questions related to CGMs. Do you have any experience, Tiffany, in patients who are on dialysis and using a continuous glucose monitor, and whether that's been accurate?
Yes, I think it's accurate enough. I think that, you know, if you really are doing a lot of glucose monitoring, you're going to find variability. And so I think that it's giving us the right range where the blood sugars are. If we're having problems with accuracy, what I generally, or somebody who's concerned more about accuracy, I generally have them calibrate for the first couple days in the morning when the arrow is flat. So if for the first couple days, while it's warming up, especially day one, the accuracy may not be as good. So do the finger stick calibration first thing in the morning when the blood sugars are like 110 and flat. And 110 was very specific. You know, when the glucose values are stable and in a normal range, that's when you're going to get the most accurate data for the CGM. You could calibrate then, and it should help promote more accuracy. What I tend to see is like if the blood sugar, you're laying on it and it gives a 40 and you've had a bunch of juice and the blood sugars are rising and you're having wild fluctuations with the blood sugars, that if you try and calibrate then, you're actually going to promote more inaccurate data. So calibrating good information and good information out instead of trying to correct when you're having some off values. But day one and, you know, right before the end, you might get some data that's not as good either. And I think that people who are wearing this continuously, you know, they start to know when it's more reliable and when they are more suspicious.
Absolutely. Yeah, that's really helpful. In my experience also, I have some patients on dialysis with continuous glucose monitors, is that it is generally fairly accurate. There's another question. Do you hear from them if patients have a lot of sweating, or if they're like constantly in a pool, about these devices falling off, or any there?
I worked a little bit at Camp Joslin here, the diabetes camps for kids, and this technology is meant for wear and tear. If you see the kids going around and just how these like 12-year-old boys are managing their diabetes, I would say that for when I'm working with somebody who is in construction or something and they're outside and sweating a lot, you know, sites, trying to move it around to areas where they might not perspire as much. Hair, some of my patients may need to shave and use certain areas to be able to not have the hair underneath the adhesive. They're like that Panther Diabetes that somebody posted. They have some different adhesive tapes, skin tack. There's little tapes that you can put on your skin before. The skin tack's great because it's adhesive, but it also provides a little bit of a barrier. And then you can go on Amazon and there's just so many people selling different types of over patches to put on top of it so that you're getting it, especially for those people who are swimming a lot in the summer. But Dexcom and Freestyle Libre are reasonably reliable at, if you have a sensor fall off before the full time, if you reach out to them, they will replace it. I recommend my patients go to their phone app and just send an email so they don't have to wait online on hold with the company for like 45 minutes to get it replaced.
That's really helpful. One last question about insurance coverage. I'm not sure whether you know about this, Tiffany. So there, for patients with hypoglycemia, who may not necessarily have diabetes, the CGM can be covered. There's a question of, does it need to be a true like blood sugar less than 55 on a blood draw, or could it be kind of rebound hypoglycemia?
I think that different insurance companies have different policies. I would have to say that I don't use a lot of CGM for hypoglycemia personally. I feel like when I have patients come back with blinded ones, a lot of the symptoms don't correlate, and we are getting some false alerts for the lows, some like potentially overnight. And I don't have a lot of patients using these for hypoglycemia. And I think it's dependent on the different insurance company.
And there was a question about, can patients with gestational diabetes get covered for CGM?
Yeah, they can. It's different for different insurance companies and states, but certainly any of them on insulin. We use the Dexcom G7, has been approved in pregnancy by the FDA. And I believe the Freestyle Libre 3 is pending, or they recently got approved in pregnancy for CGM use. And then so for diet controlled gestational diabetes, I think that's insurance dependent, but I do have some of my patients with gestational diabetes using just diet controlled using the CGM. It's complicated because the margin of error in pregnancy is so tight that we generally, for our patients with gestational diabetes using the CGM, we have them calibrate and give us a finger stick glucose every morning to get below that target of 95. Where with somebody with type 1, we're not concerned if they're, 90 or 110 in the morning, but that makes a big difference in the gestational diabetes.
Wow, I have learned a lot personally in this talk. So thank you so much for your insight and your advice. This was really helpful. So I just have one more case to go on to, and then we should have a little bit of time still if there are further questions. And so we'll go ahead and go to this next case. This is a case of a 72-year-old female with very brittle type 1 diabetes and hypothyroidism. Her A1C was 7.3%. She was diagnosed at age 42. She has a history of peripheral neuropathy, microalbuminuria, and also a history of hypoglycemia unawareness. Her weight is 50 kilograms. She's on glargine 10 units in the morning and aspart 3 to 5 units with meals. And on review of her continuous glucose monitor, there's a pattern of pre-dinner hypoglycemia, 50 to 60 milligrams per deciliter. She's relatively asymptomatic, and it's on 3 days per week. So very clear pattern, and it's not attributable to her diet. Any thoughts about what this could be? Or questions you might ask? Going for a walk, playing with a grandchild, cleaning, exercise, activity level. Yeah, you absolutely hit the nail on the head. Excuse me. So this is somebody that does not really exercise per se, but she does a lot of laundry, and she actually she lives in Somerville, which is this kind of city suburb of Boston, with these triple decker houses. So she lives on the third floor, this third floor apartment, and the laundry's in the basement. So she is up and down. She lives with her mother and brother and sister-in-law, I think. So she's up and down these stairs multiple times a day, only on these 3 days a week when she's doing laundry. And it's usually in the afternoon after she's had lunch and taken her insulin for lunch. So this is just a piece on exercise-induced hypoglycemia in type 1 diabetes. And we'll go through some strategies, but I'd love to hear also from Tiffany, her experience with this, since she sees a lot of patients with type 1 diabetes. But the effect of exercise on blood sugar varies with the intensity and the duration of exercise, as well as the type of exercise and the prevailing plasma insulin level. So this slide summarizes the differential effects of aerobic versus anaerobic exercise. I'll show that piece in a minute on blood sugar in patients with type 1 diabetes. So starting with aerobic exercise, you can see that glucose uptake into cells increases at the start of aerobic exercise. And in patients without diabetes, endogenous insulin production will subsequently decrease and glucagon production will increase, leading to an increase in hepatic glucose production, which maintains blood glucose levels steady. But in patients with type 1 diabetes who are on insulin, or really anybody on insulin, insulin levels are fixed and cannot be regulated endogenously. And so as blood glucose levels fall, there might be a small increase in glucagon and catecholamines, but the response is insufficient. And then blood glucose levels will often continue to fall. However, in contrast with anaerobic exercise, such as short sprints or high intensity intervals or resistance exercises like weightlifting, it's common for patients with type 1 diabetes on insulin to experience an increase in blood sugar, which is driven by an increase in catecholamines and growth hormone. And with anaerobic exercise, the relative roles of insulin and glucagon decrease. So some strategies that might be helpful for these cases: reducing the prandial insulin dose prior to aerobic exercise. Exercising shortly after taking an injection of rapid-acting insulin may result in faster absorption of the insulin and also a more rapid decrease of the blood sugar than usual. Other strategies: aiming for a blood sugar above 200 or some other threshold prior to exercise. So that might mean taking a snack. For patients who are on an insulin pump, you could do a number of things. You could set a temporary basal rate or suspend basal insulin delivery altogether, or use exercise activity setting. Additionally, incorporating anaerobic exercise into aerobic exercise might be helpful. So like short sprints or high intensity intervals. Tiffany, your experiences with this, any other thoughts?
I mean, it's a big impact as well is if they're going to go for a 30-minute run or if they're going to be hiking all day. And so it's the timing as well. You know, I also am fascinated by the relatively low activity potentially of yard work, or like just raking or being outside planting, how doing it for a long period of time can have the blood sugar slowly drop as well. So just having patients think about their patterns, how they reacted last time with their blood sugars. I think the big thing is that our patients, before, we'd have them raise their blood sugar by having a snack or giving less insulin, but now on these new pumps that are giving more insulin when the blood sugar is high, you know, just trying to counsel my patients not to raise their blood sugars on the pumps that give more insulin. It generally works better to exercise before a meal when there's less insulin in the system, so they don't have as much of a drop in the blood sugar.
Yeah, your comment about you know, like yard work, it's very true. I just actually, a few days ago saw a patient of mine who has type 1 diabetes, and she's like a marathon runner. She's constantly running. And she said the thing that drops her blood sugar the most is when she's outside doing yard work. So it's really interesting. This is the last case, and I have some summary slides. Any questions or comments related to this? I don't see any. So I'll read my summary points, and then there might be a few additional questions I saw in the Q&A that we can address, and happy to take any other questions. So in summary, it's important to choose and titrate medications to promote weight loss in type 2 diabetes. So as we know, most type 2 diabetes medications affect weight in one way or the other. If it's possible, if A1C is at goal, and if a patient desires weight loss or would benefit from weight loss, then it's really important to think about reducing the insulin dose. Maximizing use of insulin-sparing medications can be really helpful in this. Metformin, GLP-1 receptor agonists, or the GIP, GLP-1 receptor, the dual receptor agonists, SGLT2 inhibitors, all are great options. In general, the greatest weight loss you'll see is with tirzepatide over semaglutide over dulaglutide, but at the high doses of semaglutide and dulaglutide, you can also see really meaningful reductions in weight and certainly in A1C improvements. We also talked about in patients who are on basal insulin and whom you're starting a GLP-1 receptor agonist, you should empirically decrease the basal insulin dose by 20% if the A1C is less than or equal to 8%, just to avoid hypoglycemia. In terms of U500 insulin, with a concentrated insulin, the same dose can be delivered in a smaller volume, leading to improved absorption. Remember that the pharmacokinetics of U500 are a little bit different. So it really is an intermediate acting insulin, and so it can be given twice a day, or in some cases 3 times a day. If you're converting to U500, you'll calculate the total daily dose and consider giving less if a patient is well controlled or they're at risk of hypoglycemia, or if you're adding other medications that might also increase their risk for hypoglycemia. And there was a question I saw in the chat about, do you ever convert patients if you switch them to U500 or they're on U500, do you ever convert them back? And yes, all the time. And that's a very beautiful thing when you can do that. So ways to do that are really to try to maximize your other medications that help promote weight loss and help improve A1C. And we've had really good success with doing that. And that feels so good to be able to, in any way you can reduce insulin or switch back to a non-concentrated insulin. We talked a lot about continuous glucose monitors. They're wonderful devices that can really help patients a lot with improving their A1C, also reducing the risk of hypoglycemia given the alarms. I agree completely that for patients with type 1 diabetes or patients who are on multiple injections of insulin, this is really standard of care. But there have been some, in terms of other patients who have type 2 diabetes or who are only on insulin once a day, there have been some changes to eligibility requirements for these. And so, I would strongly consider prescribing these for patients who are on any insulin, even once a day insulin. And then there's some other circumstances like hypoglycemia for whom you might be able to get insurance coverage. And then finally, to mitigate exercise-induced hypoglycemia in patients with type 1 diabetes, some strategies are reducing the prandial insulin dose immediately prior to exercise, or as Tiffany mentioned, exercising prior to eating and prior to taking your prandial insulin, aiming for a blood sugar slightly higher, so maybe a snack, except for if patients are on a closed loop hybrid pump, in whom that might actually promote more insulin delivery. If they're on a pump, they can reduce or suspend their basal rate or use exercise mode, and then considering incorporating anaerobic exercise into their routine. So I'll pause there. And I think there were a couple of other questions. There was a question about GLP-1 receptor agonists. Is there a BMI below which you hesitate to prescribe? That's a really good question. I have to say, most patients that I'm seeing with type 2 diabetes in my clinic do not have a normal BMI, unfortunately, but I definitely hesitate if someone is concerned about weight loss. And so usually those are patients with BMIs or in whom I'm concerned about weight loss, like 19 or 20 or something, who really, it's usually older patients and their weight loss or low weight is related to other factors, but I'm really worried about causing more weight loss. I would definitely hesitate to prescribe it in that case. But if someone has an elevated BMI, then I would certainly not hesitate. Tiffany, do you have any other advice about that?
I would say with you, if I'm concerned about them losing weight, but for a lot of my patients, I'm amazed at how it can improve their glucose control, even without significant weight loss. And it's just so highly variable. And I do sometimes think that this data in the studies is, challenging to interpret because we do have patients that lose so much weight, but I think it's often, I don't see a lot of weight loss in many of my patients, but I can see an improvement in the A1C with the, so I think it's okay to use it with somebody who is, BMI in the normal range, but we need to improve their blood sugars.
It is a very good point. The response is so variable. And I've had patients who are on 0.75 milligrams of dulaglutide and lose a ton of weight, which is shocking to me. And I've had patients on really high doses of semaglutide who aren't really losing a ton of weight. So it is so variable. And you could certainly always consider, a low dose of a GLP-1 receptor agonist and kind of see how they respond. But it is quite variable. And there's a question about, is anyone getting a GLP-1 receptor agonist covered for a family history of cardiac disease? I have not seen that, so I'm not aware of that. And I think that may be all of the questions we have. If there are additional questions, feel free to unmute and ask or type into the chat or the Q&A. I think we have, we just have a few more minutes. So if there are additional questions, happy to stay on and answer them. Otherwise, please feel free to enjoy the rest of your day. And thank you so much to everyone for attending and for your participation. And we hope this was helpful. And a special thank you to Tiffany for joining for this. Really appreciate your insight.